Only bug that needs to be eradicated for the first growth that has evidence is Pseudomonas. Treating and eradicating Pseudomonas at the first growth before it becomes mucoid is going to impact mortality. So you're going to save life and improve longevity, the long-term outcomes, if we are able to treat it in time. All the other bugs do not need to be eradicated. The difference between is when you have those exacerbation scoring index. So look at the FE1 drop of 10%. There are international registries. There's definition of exacerbation now. So exacerbation need to be treated, not colonization. Great point, Sir Ahmed.
Thank you.
Yeah.
Thank you very much, sir. We are just running out of time. Thank you very much. We'll have some questions at the end. Thank you very
much. Sure, anytime I'm here. Thank you so much for having me here.
So our next speaker would be Dr. Muhammad Naeem, and he will be live from USA on Zoom. Dr. Muhammad Naeem is a graduate of Dow Medical College, and then he did his residency and fellowship at Washington University in USA, and he is currently working as assistant professor in cardiac, vascular, and thoracic imaging division at Emory University in Atlanta, Georgia. So can we just connect the Zoom, please?
Yes, it's connected, sir.
Dr. Muhammad Naeem, can you hear us? Dr. Naeem, can you hear us?
Okay, so thanks for the invitation. I'm going to talk about imaging cystic lung disease. It's quite a niche topic, so I will try to cover the common one that we see in clinic. I will not cover any rare cystic lung disease. I hope I can finish this in 30 minutes. So for the pulmonary cyst, whenever we are talking about the pulmonary cyst, they are considered to be rounded at all lucency within the membrane, so you can actually see a histopathologic specimen. And by definition, they can have thin wall less than 2 millimeter, and they're permanent structures. And we are increasingly seeing them in the era of multi-detector CTA. Most of them are not even part of the cystic lung diseases; they are just part of the normal aging process. And whenever we encounter pulmonary cysts, these are the 5 cardinal questions that we should ask. The first is whether this is a true cyst or not. And if it is a true cyst, you should differentiate it from the cavitary disease of centrilobular emphysema or cystic bronchiectasis, etc. If they're in subpleural location, you should rule out paraseptal emphysema or usual interstitial pneumonia, such as honeycombing. And when they are intraparenchymal and they are more than one and they're scattered, then you are dealing with cystic lung disease. And when you are dealing with cystic lung disease, the next question you should ask, do you see any nodules associated with cyst? And do you see any ground glass associated with cyst? And we will talk about those diseases that can cause that leakage. Now, whenever I'm reading any chest CT for the diffuse lung diseases, I use this DALCO approach that was taught to me in residency. And DALCO is just a mnemonic. D stands for demographic. Whenever I open a case, I usually look at the age, the gender, smoking status, and HIV status for the patient. Equity is very important in radiology, so comparison to the prior imaging is very important, whether this condition was present on the prior or not. Location of the cyst is very important, whether it is upper lung predominant disease or lower lung predominant disease on the coronal images, and on the axial, whether it's diffuse or just clustered to a focal area. P in this mnemonic is the pattern, whether you are dealing with pure cysts, whether your cysts have associated nodules or whether they have ground glass with them. And then other findings are very important. For example, if you see renal masses on the chest CT, you might be dealing with cardiac masses, bone findings, lymphadenopathy, and pleural effusion. Now let's talk about some of the definition for the cyst mimic. So we already talked about the cyst, that these are the rounded parenchymal lucency, and they have thin wall. As compared to the emphysema, in emphysema you can take a pencil and make borders around it, whereas in cyst, there should be surrounding normal lung, unless it's a very advanced cystic lung disease. On the contrary, cavity usually a very thick perceptible wall, and cavities can be associated with consolidation, mass, or nodule. And if it's associated with a consolidation, usually you're dealing with infection. And usually infection-associated cavities will have air fluid levels in them. So whenever I see air fluid level in a cavitary lesion, usually I'm dealing with an infection.
Another mimic is bulla. So bulla is considered as a rounded focal lucency or area of decreased attenuation, and it measures greater than 1 centimeter, usually several centimeter in diameter, and can cause compressive symptom on the normal long parenchyma and might require bullectomy. And bleb, on the contrary, are smaller. They are less than 1 centimeter. Classic location is usually in the lung apices under the visual flora, and often seen with thin, lean, young patients. And we have also seen that they are now being part of some connective tissue diseases like ACTA2 mutation. And these patients are thin, tall, lean patients, and they just present with spontaneous pneumothoraces from the rupture of these blebs. So pathogenesis is rather complex, so I'm not going to go into detail for every single disease, but these are the 3 major mechanisms that happen for the cyst formation. We have proteases in our body, which are basically molecular scissor, and they're always in the inactive form in the lung. But what activates it's usually smoking, and it can also be activated by other factors. So when they get activated, the proteases can cut into the elastin, and when the lung heals, it can actually cause cyst formation. The second mechanism is seen with the infiltrative diseases like lymphangioliomyomatosis, where the smooth muscle infiltrates into the peribronchial tissue and can cause check valve mechanism where the air can enter into the alveolus but cannot escape, and over time the alveoli can dilate and form cyst. And then the third mechanism is usually peribronchial ischemia and necrosis, which can lead to cyst formation. Now, there is no classification scheme in the textbook, and with the CT, we are seeing that as many as 25% of the patients who are older than 75 years may have cysts without cystic lung disease. So we have to be very careful when we are interpreting these CTs and not call cystic lung disease on every patient. But when I'm approaching these cystic lung diseases on imaging, I usually divide them into 4 different categories. So if it's mostly or only cyst, I'm probably dealing with one of these diseases like LAM, Langerhans histiocytosis like gem deposition disease, Birt-Hogg-Dubé syndrome, or cystic metastases. If the cysts are associated with nodule, it could be smoking-related Langerhans histiocytosis or amyloidosis. If the cysts happen with ground glass, I'm either dealing with smoking-related BIT or I'm dealing with pneumocystis pneumonia. And if the cyst happen with ground glass and or nodules, then you might be dealing with LIP. So before we delve into the cystic lung diseases, sometimes we can see focal cyst as part of infection or inflammation of congenital diseases. So this is the infection which is associated with human papillomavirus, which is the recurrent respiratory papillomatosis. So these patients get papilloma of the trachea or the airway, and every time they cough, they aspirate these small particles into their dependent lungs, and over time they cavitate. And because it's an HPV infection, they are at increased risk for squamous cell carcinoma formation. And you can see that this poor patient, who's only 26-year-old, acquired through the birth canal HPV infection, and now you can see that there's a huge squamous cell carcinoma on the floor. Some of the malignancies can cause cystic appearances, especially the pseudocavitary type of lung adenocarcinoma, and these are increasingly being recognized and are also increasingly missed by radiologists also. So usually these patients will have cluster cyst, can have surrounding ground glass, thick septation, and not. Then you can have congenital anomaly where you can have cluster cyst as part of the congenital pulmonary airway malformation. And then sometimes fire eaters pneumonia with aspiration can cause this. This is very rare. Now, when we're dealing with mostly or only cyst, we can talk about some of the diseases. So the most common one is lymphangioliomyomatosis, LAM. And LAM is caused by the infiltration of the smooth muscle cell. Nobody knows what's the origin of these smooth muscle cells. And this is the disease that can recur even after lung transplant. And we have seen that these diseases have recurred in patients as far as 20 years after their lung transplant. Now, the LAM can be part of the tuberous sclerosis complex or can be sporadic. Now, sporadic LAM happens almost exclusively in women. We have probably seen 2 cases in our institution that happen in men, and usually affects younger patients, 35 years or below, and the lesions are in lungs, kidney, and lymph node. Whereas tuberous sclerosis is a systemic process, so you will see lesion in the entire And the mutation is, and usually there is associated mutation in the mTOR pathway, and that's why sirolimus has been used to treat these patients. May I request the person who is talking to please?
ये presentation हो गई थी इनकी हो रही है
मैम अभी हमें हमारा हॉल 2B में डॉक्टर मोहम्मद नईम ऑनलाइन है
ये है ना
Okay, so the imaging findings in LAM is usually patient presents with large lung volumes, can have abnormal lung architecture, can present as emphysema in the advanced stages. And the
तमाम साहब का हो रहा है ऑनलाइन है ना ये हो रहा है
excuse me, can you please quiet?
ये दूसरा चल रहा है इसके अलावा तो इसमें तो नहीं है ना
Sorry, Dr. Naeem, we are trying to control this thing is outside. Yeah, just okay. Please continue. Thank you. Sorry for inconvenience. Sorry. Hello. What? Okay. Just hold for a minute. Sorry. Just.
Spontaneous pneumothorax. The saying is that if you have a young patient with spontaneous pneumothorax, especially a woman, it's LAM unless proven otherwise. The other imaging findings that you can see are the diffuse cyst. They do not have any zonal predilection, and usually they're tiny and scattered. And in the advanced stages, you can see that they can actually mimic emphysema. Pseudo-beaded appearance has been described in the advanced stages, where the cysts, when they are abutting the fissures can look beaded. And then these tiny ground glass nodules can present in patients with tuberous sclerosis, and they're just type 2 pneumocyte hyperplasia. And it's a very classic feature. If we see that in tuberous sclerosis patient, then usually they do not need any gene analysis. The other imaging finding is that myocardial fatty foci can happen in tuberous sclerosis. You can actually see that there is fat deposition in the myocardium. They can have dilation of the lymphatic duct due to the infiltration by the smooth muscle cell. And then they can also have renal and hepatic angiomyoliphomas, which are just the fatty tumors. American Thoracic Society and Japanese Respiratory Society came up with the criteria for the diagnosis in 2017. So they said that in women, they just used the word women because they were talking about sporadic LAM. So in women with compatible cystic lung disease on chest CT, the additional presence of any one or more of the following is sufficient to establish the diagnosis without requiring a lung biopsy. And it could be presence of the TSC gene mutation, it could be elevated VEGF level, and the level required for the diagnosis is greater than 800 picograms per ml. And on imaging, patients can have renal angiomyoliphomas, they can have lymphangiomyomas, which is just the dilated thoracic duct, or they can have spontaneous stylus effusions. Whereas European Respiratory Society came up with their own criteria, and it also requires VEGF levels to be greater than 800. The next disease is Burton-Gilbert, and it requires the European PhD Consortium criteria, which has one major and two minor. And for the major criterion, you require these adult onset skin tumor, which are skin tags or fibrofolliculomas, or they can have germline mutation. And in the minor criteria, imaging is very important because typical lung cysts, and we'll talk about what typical lung cysts are, as well as renal cell cancer. So you require two minor criteria and one major to diagnose Burton-Gilbert or Ornstein-Wittenberg syndrome. And the imaging finding is that the cysts are very low lung predominant, and the cysts that abut the mediastinum are usually large. You can actually see that they are larger as compared to the other cysts that are in the periphery of the lung, and they are very low lung predominant. And the other feature that has been described is that the cysts that are away from the mediastinum usually have usually are smaller and have a smaller attachment to the pleura. And one of the other features that has been described is that the cyst would surround the segmental pulmonary artery in the lower lobes. And you can see that the cyst can have variable morphology even in a single patient. And usually the cysts that abut the paramediastinal location are bigger and have septations. Cystic neoplasms can mimic cystic lung disease, so if you have a patient who has known malignancy, then metastatic disease should be excluded with pulmonary cyst. And the most common tumors that can cause cystic metastases are peripheral sarcomas and adenocarcinomas. Now, the primary lung neoplasm that can mimic cystic lesion is the pleuropulmonary blastomas and lung adenocarcinomas. And we have been seeing a lot of lung adenocarcinoma with cystic varieties that have been missed if the radiologist is not familiar with it. So this patient had angiosarcoma, and you can see that there are cystic lesions but associated ground glass. And these ground glass are basically the areas of hemorrhage in patients with angiosarcomas. The adenocarcinomas give you these Cheerio-type nodules whenever they metastasize. It's a very classic feature seen with adenocarcinoma, and it mimics this breakfast cereal called Cheerios. Squamous cell cancer can cavitate and can mimic cysts. So you can see that this patient had this small metastasis in the left lower lobe, which cavitated over time. And then pseudocavitary type cystic lung adenocarcinoma, I'm emphasizing again and again because these are usually missed by the radiologist as well because they just look like cysts, clustered cysts. Light chain deposition disease was first described as the next entity we're going to talk about. Cystic lung disease in light chain deposition disease was first described in 2006. And because it mimics amyloid even on imaging, biopsy is sometimes required. And Congo red stain basically differentiates the two entities. So amyloid would bind Congo red, light chain does not. And kappa light chain are the most common culprit, and 75% of the patient would have concomitant myeloma or Waldenstone macroglobulinemia. And this is the patient with light chain deposition disease. The cysts are usually diffuse, and you can see that they are scattered all over. And we're going to talk about this classic feature in these patients with the vessel traversing the wall as well as through the cyst. So these are the two features that have been described in these light chain deposition patients. So if you will see the cyst, you can see that multiple vessels are traversing the wall of the cyst. That is a very distinctive feature with light chain deposition. And then if a vessel is central and is traversing through the cyst, in these patients over time they can calcify and can mimic calcified granulomas and are often mistaken for granulomas. And if you're not familiar with that feature, these patients might be mislabeled. Cysts with nodules are seen with Langerhans cell histiocytosis and amyloid. And amyloid, because it is very close to light chain deposition disease, both in terms of imaging and diagnosis and patient population that it affects. That's why I'm just going to describe it soon after the light chain deposition. So amyloid can be systemic or localized to one organ, affecting one organ, and localized presents with multiple pulmonary nodules that can cavitate. And rarely it presents with diffuse cystic lung disease, and often 38% of the patients can have concomitant lymphoma. So the more nodular the amyloid is, the higher the risk, and therefore sometimes it requires lung biopsy. But one of the classic features that we see with amyloid is that whenever the nodules and masses happen with the cyst, they calcify. Calcification is a very classic feature for amyloidosis. And if you see a nodule that is not calcified in a patient with amyloid, you should always think about lymphoma, pulmonary lymphoma. And biopsy is recommended for any non-calcified nodule. And these cysts are usually diffuse and can mimic light chain deposition, especially when the nodules are not calcified. Langerhans cell histiocytosis that I'm going to describe is the one that is associated with smokers, and usually the patients who present are young adult smoker. And the pathogenesis is that cigarette smoking results in the accumulation of Langerhans cell in the peribronchial region that can lead to cyst formation. And because these patients have mutation in the BRAF and MAP2 kinase pathway, LCH is considered a dendritic cell neoplasm. And whenever the smoking cessation happens, many patients get stabilization of the disease and sometimes complete resolution, and few develop the progressive lung disease even after the cessation of smoking. And in those patients, the targeted therapies have been tried, like BRAF inhibitors, and sometimes chemotherapy is used, like cladribine. And lung transplantation is the last resort if the disease is very progressive. And distribution is the key in differentiating pulmonary Langerhans cell histiocytosis from other cystic lung disease. Now, one of the features that has been described in Langerhans cell histiocytosis is one of the features that has been described in patients with Langerhans cell histiocytosis is the nodules look like Cheerios. Same as the pulmonary adenocarcinoma, you can see that the nodules are thick walled here. But the classic feature is that Langerhans cell histiocytosis never involves the cluster phrenic sulci. It almost always spares. Even in the advanced disease, we have never seen the involvement of the cluster phrenic sulcus. So that is a very classic distinctive feature of this disease. And you can see that it also has a Cheerio manifestation. So the nodule happen early in the disease, and the nodules can cavitate, and you can actually see that these nodules have thick wall and are cavitating and are irregular in shape. And in the advanced disease, the cysts are formed. And even in the advanced disease, you can see that this patient has nodule, cyst, and these cysts are very bizarre shaped. But what's interesting is that the lung bases are spared. The costophrenic sulci are spared, even in the advanced disease, which is a very distinct feature of this disease. The next entity is with ground glass. Usually two diseases come to mind when you are dealing with cyst and ground glass. Is the DIP related to smoking that I'm not going to talk about, and then pneumocystis pneumonia. So we see a lot of PJT because Atlanta has one of the highest AIDS population in the US. So it usually happen in immunocompromised individual with predominant AIDS and CD4 counts less than 200. And the cystic form of pneumocystis is more frequently seen in patients receiving aerosolized prophylaxis. And ground glass is the principal finding. So almost all the patients that we see with PJP or PCP have ground glass, and the ground glass affects the upper lung most of the time. And you can see that this peripheral sparing is seen in almost half of the patient and can mimic pseudopneumothorax. So it's a pseudopneumothorax, and where the ground glass is diffuse, but it spares the extreme periphery of the lung. And the rare features are these. So PJP rarely gets consolidation, rarely gets nodules, rarely gets lymphadenopathy, and rarely gets pleural effusion. So if you have a patient where you are suspecting pneumocystis pneumonia, but you see any of these features, then you should think about alternate diagnoses. And the cysts are small, thin-walled, and they're basically infectious pneumatocyte. Now the thing is that these patients can develop this aggressive form called bullous pneumopathy, which is very rare. So this patient had presented with this. Even with treatment, he progressed and had this bullous pneumopathy. These cysts ruptured, and he had massive pneumothoraces and alveolar-pleural fistula, and died because of the complications. And the last entity is the cyst and ground glass, with or without nodules, is the lymphocytic interstitial pneumonia. Recognized association, most common is Sjogren. Even though in the books they say AIDS, in our clinical experience, adult onset AIDS rarely gets LIP. The LIP that we see in AIDS patients is usually congenital acquired AIDS. It's considered a benign lymphoproliferative disorder, and 5% may transform to lymphoma. So this patient had Castleman disease. So Castleman's disease usually present with these chunky lymph nodes in the axilla, mediastinum, everywhere. So this patient had these enhancing lymph node in bilateral axilla, in the mediastinum, and then had this cystic lung disease. And the classic feature with LIP related cystic lung disease is that cysts would have internal architecture. And this is a very helpful feature. You will see a septation within the cyst almost all the time in patients with LIP. And it's a very helpful feature when I'm reading these cystic lung disease cases. The nodules can happen with LIP, and they're ill-defined and are usually along the bronchi. And you can see that I magnified one of the nodules, and you can see that it's encircling the bronchus. Ground glass changes can happen with cysts in LIP. Mediastinal lymphadenopathy is very common in these patients, and thickening of the bronchovascular interstitium. So you can actually see that this is the vessel and this is the bronchus, and the bronchial wall is very thick and mimics chronic bronchitis. So in summary, LAM or tuberous sclerosis would have uniform diffuse cyst, and in patient with tuberous sclerosis you might see ground glass nodules, which are just type pneumocyte hyperplasia. Because they have mTOR pathway mutation, they are at increased risk for development of malignancies. Burke-Hoggle-Bay would have skin lesion. The cyst would be in the lower lobe, and the larger cyst would be along the mediastinum. And they also get tumors such as renal cell and oncocytomas. Light chain deposition disease, often seen in patients with multiple myeloma. And one of the features with cystic lung disease and light chain deposition is that the vessel will be traversing the wall of the cyst. Cysts are usually diffuse. Nodules rarely happen, but when they happen, they're very peripheral and subpleural in location. And lymphoma can happen in these patients. Pulmonary Langerhans cell histiocytosis related to smoking would have bizarre shaped cyst and is very upper lung predominant. And even in the delayed phase of this disease, the claustrophrenic sulcus would be spared. The nodules are irregular and stellate shaped, and because they have BRAF mutation, they can get different malignancies, usually the myeloid neoplasm like AML, and lung cancer, of course, because they are smokers. Amyloid can present with diffuse cyst with larger nodule, and one of the helpful features is that the nodules in amyloid would have calcification, and they also have risk of developing lymphoma. Pneumocystis pneumonia associated with HIV patient would have CD4 count less than 200 as the risk factor, affects the upper lobe most of the time. LIP associated with Sjogren, the cyst would have internal septation, and the nodules, when they happen along the bronchi. And again, these patients are at risk for lymphoma as well. And this brown arrow is to show you the distribution of the cysts. So these diseases have diffuse cysts. The one with the purple are lower lung predominant, and the one with the blue arrow are upper lung predominant. Thank you, and this is my email if you have any questions or queries.
Thank you very much, Dr. Muhammad Naeem, for this talk. It was an excellent presentation, and we really enjoyed this talk and learned a lot from you. We would like to take some questions, but because of short of time, we will take the questions at the end. If you could bear with us and till the end, then it would be really kind of you. Thank you very much again. So our next speaker is Dr. Javed A. Khan. Dr. Javed A. Khan is a distinguished pulmonologist from Aachen University, an anti-smoking crusader, and a celebrated recipient of both the gold medal from the WHO for tobacco control and the Nobel Peace Prize from UN for his contribution to lung health. And this morning, he will discuss about environment and lung health. So please.
Thank you, Mahmood.